Well, hello, Cinco de Mayo. Happy May 5th here for most of the world. Some of us down under, maybe we're already to May 6th. So wherever you are, greetings to SADS Live, program 117. I'm Mike Ackerman, genetic cardiologist here at the Mayo Clinic in Rochester, Minnesota, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. But today, like most of our Fridays, I'm here on behalf of Alice Laura and her team. Alice is the CEO of our SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, where we are devoted to you, families with SADS conditions, long QT syndrome, CPVT, ARVC, you know the name of yours, where you find this to be your home and your place of support, of advocacy to advance our insights and knowledge and understanding of your diseases, to be here for you, and hope you found that to be true for the SADS Foundation and for our Friday get-togethers. We've been doing this for now over 3 years. So it's great to get to be with you. I love spending the time with you. And today, like last time, it's your questions, which are always amazing, and my attempt at giving a decent answer. Now, before I see what questions start to come in, I have to give a shout out to somebody who interviewed me last week or last time. Julie, as you know, I won't say her last name unless she reveals it, but she sent me this afterwards with ACK. So Julie, thank you. I like my new hat. So thanks a lot. Also a shout out to, I don't know if you can see back there, but Alexis, who has, her name's been shared before, but she and her mates are world jazz dance champions, just having won between about a week ago, or I think I learned on Monday. So congratulations, Alexis. So proud of you, as I am for so many of my patients and the families where I've had the privilege to be your genetic heart specialist. So it's a privilege to be that. It's a treat to get to be with all of you, whether I personally have gotten to care for you or to be counted as your doctor or not. So let's see what questions start to come in. While they're coming in, some of you who follow me on Twitter at MJ Ackerman, MD, PhD, you might have seen an announcement of something that joined my life's highlight reel Wednesday night. And it was amazing. And the amazing thing is this. My daughter, Grace, took her mother and me up for our first flight. So our daughter, she's 19. She just recently completed her commercial multi-engine pilot's license and commercial single-engine pilot's license, has 300 hours so far. And she finally took us up the day after finals for her. So she needed to have that out of the way. And we had an amazing 90-minute flight Wednesday night. And so I'm still on cloud 9, as they say. And if you want to see a picture of cloud 9, this is one of the pictures from my flight with my daughter. So next step is when someday she'll come on a Delta flight and say, "Good morning, ladies and gentlemen. This is Captain Grace Ackerman," and giving a shout out to my dad, who's in the back of the bus flying today. And I can't wait for that kind of shout out someday. Anyway, that's enough about my family life, and now the focus on yours. So you're joining in, and there's a really neat thing you're going to want to put on your calendar for 4 days from now, May 9th, Tuesday night, 7:30 p.m. Eastern. We're going to have 5 teens, young adults, take questions from teens about life with your genetic heart condition, teens only. And then the next week, May 16th, same time, 7:30 p.m. Eastern time, the moms and dads of those teens, they get to have their own private session. So now with that, as I always do, I don't pre-select. I look off to the side. So when you see me looking off camera, I'm reading your question in real time. They're not sent ahead. And I take them from top to bottom. So I don't cherry pick. And then we figure out whether I have any ability to answer your questions. And they're getting harder, I must say. You are amazing with the questions you ask. Some of your sentences are getting longer. So remember, word of the day again, pithy. Keep that question pithy so that I don't get tempted to skip it. Well, we have 35 minutes on the counter, and let's do this together. Krishnan gets question number 1. Does repolarization reserve play any role in long QT patients with ascertained prolonged QT intervals being asymptomatic? Now, if that's apparent, that's a pretty sophisticated question. So I guess maybe we have some medical professionals, maybe eavesdropping in, joining us, whatever you are, Christian, welcome. So what that is getting at is we speak of the term repolarization reserve to talk about the health of the heart's recharging system. And when that reserve is compromised, either genetically, genetic long QT syndrome, or exogenously, because of the presence of acquired exogenous QT agitating risk factors, that sets up the person to be able to show that the reserve is reduced by having a prolonged QT interval. Now, that the reserve itself may or may not have anything to do with whether you're symptomatic or not. So I don't think there's necessarily a direct link there. The reserve has more to do with showing, besides our long QT patients' primary mutation that can cause long QT syndrome, why do some show that their reserve is reduced? They have a long QT interval, their ECG is abnormal. And why do others who own the mutation show a normal QT interval? What else is going on that's keeping their repolarization tank, their reserve, full and not showing the consequence of the presence of the mutation? Carlene is asking, is there any connection between mast cell disorder and CPVT, catecholaminergic polymorphic ventricular tachycardia? Short answer, no. There's no connection that I'm aware of at all. Now, some patients with mast cell disorder can transiently show a prolonged QT interval, but it's not meaning they have long QT syndrome. It's sort of the agitation, the autonomic agitation, if you will, of that mast cell disorder can reduce the repolarization reserve to the point where sometimes the QT interval can be longer or longish, if you will. Mohammed, one of our pediatric electrophysiologists, and it's great having Dr. Ibrahim often with our program, asking if I would extract an ICD that was placed in the setting of secondary prevention, later proved to be related to TECRL QT prolongation, who's now responding well to Nadolol and flecainide. Well, that's getting really sophisticated. And so I don't want to distract too many of our SADS community with some of those details, but just to say that a decision to remove an ICD device is very complicated, isn't it? So there are some families, including a family I recently saw, that's had an ICD present for over 20 years for a diagnosis that they don't even have. So how do you rewind the clock and not just remove a diagnosis, reclassify them as healthy, and then remove their hardware that they never needed in the first place? That's heavy. That's complex. Now, in this case, he's saying, the person needed it, they got it, but now we understand more about it. And given what we know is the cause, we now are gaining confidence in non-defibrillator treatment strategies. So therefore, if we now have confidence to not need the ICD, do we need to keep it? And that's another tough conversation. And for my patients and families where we're deliberating that, the answer is it kind of depends. Why did we get it? How is it behaving? Are we having one complication after another from the device? If yes, and now I don't think we need it anymore because we're smarter now than we were then we work to remove it. If we're not having any problems with it, even if I've gained confidence that I might not need it, may I kick the can down the road and wait for the battery to run out and then decide? We sometimes do it that way as well. Sabrina's asking, hi, Sabrina, should asymptomatic children who play sports also take flecainide with their beta blockers for their CPVT? Well, sports or not, that doesn't really matter to me. What really matters to me is whether they're an athlete, an artist, an academic, what does their stress test look like in CPVT? And if on beta blocker therapy, I've made that stress test look like mine, normal, to where I can't even suspect the presence of CPVT, then I don't necessarily add flecainide as combination therapy. But if I still don't like the ECG stress test to where I can still make the diagnosis of the condition, then increasingly we are the community of CPVT specialists going straight to combination drug therapy of nadolol and flecainide, with the goal being to try to cure the stress test, to make it as hard as possible to even be able to suspect the presence of the condition. And I try to cure that stress test, whether my patient with CPVT is an athlete, an artist, an academic, whoever he or she is. Love the question. Beatrice, and I'm already caught up with this one, so you better get fast finger question for the next one. So Beatrice has a 12-year-old son, and his QT number was 520. Immediately placed on CoreGuard, which is the generic name for, or the trade name rather, for nadolol, a beta blocker. His max QTC is now around 490. He did genetic testing, and now they found him to have something completely different, a mutation in a gene TNNI3. That's a unique gene causing a unique genetic arrhythmia syndrome, for which it normally shows some features of heart muscle disease, hypertrophy. And so she's wondering, is that form associated with QT prolongation? Woo! Questions are amazing today. So first, the QTC number going from 520 to 490, does that mean the nadolol shrunk the QTC? Probably not. Probably what's happening is we have two different snapshots in time that shows that patient's, your child's relative QT swing. So I would not necessarily be giving nadolol credit for making the QTC less, the first point. The second is, it looks like they didn't find a long QT syndrome reason for that QT number, but instead they found a different genetic heart condition altogether, for which sometimes there may be QT prolongation. And the answer is sometimes there is QT prolongation. So does that child need to be on nadolol, which we use for long QT syndrome, for when there's a different reason for the QT prolongation? And there the answer is maybe, maybe not. We don't necessarily know a lot or enough about that form of heart disease to know whether we should be on nadolol. I like nadolol. I like nadolol for a lot of diseases besides pure long QT syndrome mediated QT prolongation. I like it, as you know, in CPVT. I have some of my patients with hypertrophic cardiomyopathy on nadolol, so may not have a real need to change anything. And so the next one is from Muhammad, wondering on a virtual consult. I'll just make a comment in general. So one of the things that was a beautiful thing, not too many things to say beautiful about the pandemic, but one of the things that happened in the United States during COVID-19 pandemic is we were allowed to connect with here, there, everywhere without being licensed in that state for an initial consultation. So I saw patients all over the country, all over the world for their first evaluation virtually by video medicine. It was wonderful. But as of Monday, I think, or a couple days, the COVID-19 pandemic emergency mandate has been declared over in the United States. And unfortunately, with that declaration, the ability to practice across state lines for the first video consult is no more. It's a terrible thing. We need SADS Foundation. We need other organizations to say, what are we doing? Why are we taking away one of the best things we had going for us in medicine? And so what that practically translates as is, as a licensed physician in the state of Minnesota, Arizona, and Florida, those are the 3 states that I have licenses right now, I could see a Floridian for a first-time consult by video next week. If you are from New York as a patient and you want to be seen by me, that first-time visit as of next week cannot be by video. It has to be on campus, face-to-face, and then the other visits can be virtual. And so unfortunately, we are going to lose, starting next week, in healthcare, one of the only good advances that occurred during the pandemic. And most people don't even realize that because many practitioners don't have necessarily a national or international practice. And so we can still do virtual consults internationally. And Mohammed, your best thing to do is email me and I'll link you to our team who can do that. Now, Julie gets the next question, and you see her full name, Julie Cedar. And so this one's for you, Julie. And she said, I've seen some debate about the safety of cannabis for patients with long QT syndrome. Is it at all safe? Now, there's cannabis and then there's cannabis. So a couple of comments there. If you're talking about some of the oils, there's zero QT concern. If you're talking about inhaled cannabis, otherwise known as marijuana, probably not QT dangerous, but it is potentially Brugada dangerous. So no inhaling if you have Brugada. Now, we could have a long discussion, should anybody be inhaling marijuana? And what, in other words, do the health benefits, pain, mood alteration, etc., for those individuals who have other health issues that are making them suffer, are there health benefits of marijuana? Do they exceed some of the health concerns, not related to the QT, but other health concerns of inhalation and lung injury kind of stuff? We won't have to go there today because we'll stay focused on our SADS community. So the oils, safe. The inhaled, not if you have Brugada, and probably, my view, not a great idea to inhale marijuana anyway. But that was free. That's just my view. Renee, her son has type 2 long QT syndrome, had a left bundle branch block and prolonged PR interval, and also has an accelerated ventricular rhythm. Do I see this often? So I won't talk about your son because I haven't seen your son, but in general, patients with genetically proven long QT syndrome like LQT2, they do not have a bundle branch block. That's very uncommon. So I'd have to see what exactly does that ECG of your son's or that person's look like. A lot of patients with LQT2 will have other ECG findings, like sometimes their T waves are upside down in the precordial leads, T wave inversions. But bundle branch block, uncommon. Prolonged PR interval, uncommon. So that would make me pause and try to ask the question, could there be anything else going on? Because we hardly ever see a prolonged PR interval and a bundle branch block because of the long QT syndrome causative mutation. Marco is asking about a borderline diagnosis of ARVC at age 58. So that's young, 58, really young. I'm not there yet, getting close. And no known genetic mutation, but that person has a variant of uncertain significance, VUS, in filamin C. Now, filamin C is a protein encoded by a gene, FLNC, that can do filamin C mediated arrhythmogenic cardiomyopathy. And so he's asking, is there a way to know whether this genetic variant is the reason? Is it the cause, or is it still just stuck, meaning it's still a VUS? Shows PVCs, and those are controlled with a medicine called Sodalol, but the RV has some borderline dysfunction and a moderate increase in size. Well, that's such a good question with such a lot to unpack there, because what we need to do in genetic heart programs is we have to size up the clinical picture, the phenotype. And then if I'm suspicious about the phenotype to where I say, look, without genetic testing, I think you have disease X. And then I order the genetic test and then I get a result. So for example, let's say I saw a patient and by all of the clinical features, even before I ordered genetic testing, I told that patient, you have long QT syndrome, and in fact, you have LQT2. And then the genetic test comes back where the company tells me that there's a VUS in the gene KCNH2. Okay, they said VUS. I immediately say that's not a VUS. That is a likely pathogenic LQT2 causative variant, because we've linked the two, the picture and the genetics. Now, in your case, or a case of a minor gene, filamin C, and is it the reason for your borderline features of your heart? That's when people have to be very careful, slow down, because when that gene is not a common one, the ability to do that reflex upgrade, like I just outlined with long QT2 or CPVT or LQT1, we can't do it as quickly, should not do it as quickly when we're dealing with minor disease genes and their possibility of being responsible for that disease or that cardiac appearance. So bottom line, tread carefully. One would have to really size up the look, decide, do I even think you have genetic cardiomyopathy, and then do some additional investigations about that particular variant, and to see why did the company grade it in this ambiguous classification, meaning we don't know, we are uncertain, and whether I would have the ability to upgrade it, promote it to likely pathogenic, or demote it to likely benign and irrelevant. A lot of work has to be done in those scenarios. Sabine's asking, what are the do's and don'ts about sport and LQT1 under NADA law? Heard a lot of different points of view. Thanks a lot for that. And Sabine, I love your question. We've worked for a long time about changing the landscape for people with long QT syndrome of any genetic variety, and what they can and cannot do. When I joined the Mayo Clinic's faculty in 2000 and started its genetic heart rhythm clinic now 23 years ago, it was almost all don'ts that I inherited, that I was brought up saying, they don't get to do this, they don't get to do that, they don't get to do this. And over the last 23 years, we've gotten rid of almost all of the don'ts. And it's really do's. How can we live and thrive despite the diagnosis? Because we know it so much better. So in my world, I don't have very many don'ts for my LQT1 patients on Nadolol. Right now, about the only thing that I have as a don't, because I can't quite overcome it yet, is that LQT1 child can't grow up to be an aviator like my daughter, because they would not get an FAA clearance, so they won't be able to join Top Gun and be with Maverick. Apart from that don't or can't right now, as well as difficult to join and serve in the military if we arrive to the military recruitment center with a diagnosis of long QT syndrome under treatment. It's hard to be declared WWD, worldwide deployable, and so it's hard to serve in the military. We have some exceptions to that. So if that's passion for my patient with long QT syndrome, we work hard to try to overcome that rejection or declination to see. But for sports, many sports continue. So I want my patients to hear this message. ARVC is still a little different for our ARVC families. It's changing, but more slowly. But for my long QT patients, and I personally follow about 600 athletes with long QT syndrome, is that where you go in your sport is going to be determined by your drive, your discipline, your desire, and not your diagnosis. So it's a new day. It's a very different day than it was at the turn of the new millennium back in 2000. Next question. I guess Muhammad gets 2 today, so it's the only time you get 2, but today's your bonus day. What's the success with labetalol in difficult to treat long QT syndrome? Now, labetalol is a beta blocker. It is a non-selective beta blocker like nadolol and propranolol. I like it. I like it a lot. We don't need it hardly ever, though, because we don't have very many patients with difficult to treat long QT syndrome when we've had our other strategies in place. So I haven't had to use labetalol a lot, but chemically, one of the features that's nice about labetalol is it may, as a chemical, mimic what left cardiac sympathetic denervation is doing in terms of altering the neurotransmitter norepinephrine and where it binds on various parts of the heart cells. So yeah, I like labetalol. I'd have no problem trying it. I have not needed to use it I have about 1,700 patients with genetically driven long QT syndrome under my watch. And the number of those patients where I've used labetalol is on this many fingers, and I won't need all of them. So don't need it very often. Carla is asking, what are the symptoms? I'm not sure what we're referring to there, Carla, but then are PACs, PVCs, and IST dangerous? So PACs are premature atrial contractions. PVCs are premature ventricular contractions or extra beats, premature beats, skipped beats, and is IST, which usually stands for inappropriate sinus tachycardia, dangerous? In and of themselves, no, but it depends on what kind are we talking about, what type of PVCs, what do they look like, where are they coming from, to better say, well, those are boring PVCs, boring PACs, don't worry about them. They might be annoying if you felt them, but they're not dangerous. So it really depends on a lot of things, and that's why a heart rhythm specialist spends so much of his or her training is knowing and being able to separate out what are vanilla, premature, early beats, skip beats, extra beats that we don't even care about unless you care about them because they're annoying you, versus which are those premature beats that are indicating that the heart muscle or the heart's electrical system is ill, has a disease process for which we have to treat. Anna is asking about if SCN5A is associated to long QT and Brugada, and how does a doctor determine, based upon the genetic results alone, the patient's diagnosis? So Anna, it's a good question because SCN5A mutations that build the SCN5A encoded sodium channel can cause at least 2 different diseases, actually more than that, but let's keep it simple. If there's a mutation that makes that sodium channel leaky, So instead of to being on and off within 5 to 10 milliseconds, after 10 milliseconds, it continues to leak a little bit of sodium in for the next 400 milliseconds. That kind of SCN5A mutation produces type 3 long QT syndrome. So that's sodium channel mediated long QT syndrome. On the other hand, if there are mutations that damage the sodium channel in a way that makes that first 5 milliseconds of current less, weaky, wimpy, decreased, that kind of loss of function mutation in that sodium channel gene is responsible for about 20% of all Brugada syndrome. So it depends on how that gene mutation damages the biology of the protein that it builds as to what the look will be. Now, if it's a new mutation, how do we know which it's going to do? Well, that new mutation that hasn't been seen before, reported before, functionally characterized before, then it's based upon who owns it. And if the family who owns that new mutation are only showing long QT syndrome, well, then we probably know how that new mutation is damaging the performance of that protein. Make sense? That's a good one. Anna's getting another bonus from, well, she's sharing. I know. I'm sorry, Anna. Now I know I was being misled by the last name for a second. So Anna, on behalf of Andrew, is asking, is scuba diving off the list of things one should do for a transvenous ICD treated low risk Brugada patient? Wow, that's a good one. So before this kind of goes back to the do's and don'ts. I don't have a lot of don'ts. I'm not a don't kind of doctor. I am a what are your loves? What are your passions? And can I have you well treated enough that we can keep almost everything that's your equivalent to oxygen on the table? So if you tell me an activity and you say, that's oxygen to me, Dr. Mike, or as Julie said, act, then I say, I think we can do it. Or I say, I know that's your oxygen, but that's one that we're going to have to snuff out and find new oxygen. On the other hand, if you were to tell me that said activity is completely, utterly optional, then in my view, it's like, okay, we don't take on any non-zero risk for optional things. Now, what about scuba diving? Scuba diving, I love it. I'm a scuba diver. Sold my trombone, my high school trombone in college to buy my scuba gear way back in the day. So I love scuba diving, and a lot of my patients love scuba diving. And do I take it away from them? No. And in a patient like you described, I won't be taking it away at all. There's nothing about scuba diving that is intrinsically Brugada aggravating in the first place. Do I make a modification in the scuba dive? Yes, sometimes. And that modification for fellow scuba divers is, would we do deep, long decompression dives where we need to stop for a while to let the bubbles dissolve? And in somebody who might be at risk of a disease-triggered faint underwater and need to do an emergency ascent with your buddy, does it make sense to do a deep dive? Probably not, maybe not. In other words, now we have to do an emergency ascent and I don't get to stop. And now I have a new problem called the gas in my bloodstream type thing. So modification, perhaps, of scuba diving, eliminating it if it's your oxygen, not for your kind of scenario that Anna shared with me. So Christian has an interesting footnote that there's a relative, a follow-up it must be, who has both a KCNH2 poor mutate variant and a filament C variant, and both are graded as a VUS. And on MRI, the heart muscle looks, a word that we don't often talk about in our program, non-compacted. So the heart muscle can look thick, hypertrophic cardiomyopathy. It can look dilated cardiomyopathy. It can look different in the right ventricle, ARVC, or the muscle itself, instead of being compacted, it can look spongy, or what we say non-compacted. And so this would be one where the detective work would need to be done, where we're staring at that variant that they called a VUS and say, well, why is that a VUS in KCNH2? Does that ECG really look normal? Do those T waves really look normal? Because variants in the pore often are disease causing and not just ambiguous things. So I'm curious. I'd have to understand and do the detective work, which the point being, that's what genetic heart specialists do. They don't read genetic test reports. That's called literacy. They need to interpret those reports, weigh everything in the balance, seek that concordance. Just like a heart doctor who orders an ECG doesn't just read the report, they interpret the findings. And with that, I've reached the bottom because Muhammad, we have time. So Muhammad, you get the trifecta today. So you are living large, where I'm going to give you 3, but not again. No. But Muhammad gets the third and the final one that's on the reel, and we did all of them under the top of the hour time. And Muhammad's asking about a patient who was put on flecainide for LQT2, homozygous, difficult to treat. Not sure if that makes sense. Now, I agree with you. That doesn't make any sense at all. So for families out there, one, to have 2 mutations to do a double LQT2, that's really uncommon. So it could be that we're dealing with a situation of consanguinity where mom and dad could be related, and now the child and each own the same variant, and now the child got a double dose. That's how you become homozygous. Or if mom has long QT2 for one reason, dad has long QT2 for a different genetic marker reason, and now the child gets both, then they have compound heterozygous LQT2. So I'm assuming from the word he used is that that child has the exact same LQT2 mutation from dad and from mom. Very uncommon, probably has a very long QT interval. And the medicine that I would be adding if I did not like the control I had with Nadolol would actually be Mexilotine. So Mexilotine is a medicine that's used for LQT3, but my team was one of the first to publish with Peter Schwartz our early experience with Mexilotine in patients with LQT2. And we do see significant QT shortening in some, not all, in some patients. So my view has become, and we're putting a larger series together now, that if I have an LQT2 patient whose QTC is stubbornly staying above 500 milliseconds, I need to be trying other strategies to get that QTC below 500 milliseconds, to try to make that QTC as normal as possible. Just like in CPVT, we're trying to make that stress test on our medications to be as normal as possible. Hope that helps. And Marco, thanks for the footnote of viewing this as a great session. I'm glad you liked it. I loved it. You guys stimulate the daylights out of me, I must say, with your questions. We could do this every single time, but next time, which will actually be in 1 week, because 2 weeks from now, we and many others will be meeting in New Orleans for Heart Rhythm Society 2023, an exciting meeting. A lot of advances going to be discussed. We will be sharing at Heart Rhythm Society 2023 some of our early results with our gene therapy In our rabbits with long QT, particularly LQT1, spoiler alert, it's looking really promising. And so Sahej on my team will be sharing that. I'll be sharing some updates about gene therapy there. Many on my team will be presenting a lot of works. Colleagues all over the world will be convening together. So we will not be meeting in 2 weeks. Instead, we're going to do a bonus meeting next week. And I'm going to see if I can bring a guest on board with just a week to go to find him or her to join me. If not, we'll be back to some of the things that I love the most, your questions and spending time with you. And our time is up. So happy Cinco de Mayo. Have a wonderful weekend. Look forward to seeing you in 7 days. Remember, live and thrive despite your diagnosis. Have a great rest of your day.